اسد آواز درزی.
جی سر رضی سر.
اسد
آؤ سر رضی سر. آواز رضی سر.
آواز درزی.
جی سر رضی سر.
ہیلو
جی سر آواز آ رہی ہے آپ کی سر.
ہیلو ہیلو
ہیلو.
آواز درزی.
جی سر آواز رضی سر.
نہ دا بل بند ہے آواز درزی. اس
ہیلو. سر وہ سم آواز نہ راضی سر.
اس رضی.
جی سر وہ راضی سر.
ہاں بس ٹھیک شو. بسم اللہ الرحمن الرحیم. I think 13 student now enters. Today lecture is of uveitis. Uveitis is a very complicated disease affecting the eye, interior segment, posterior segment, and the whole eye. Its prevalence is not clearly present in literature because of its onset and because of less studies in the community. But those who have reported that about 50 or 64 per 0.5 million یعنی 1 لاکھ. تو ڈفرینٹ ویلیو آ رہے ہیں. بعض لوگ 34 اور 36، بعض لوگ 64 ویلیو دیتے ہیں اس کی کہ یہ اتنا پریویلنس ہے. اور اس میں جو زیادہ تر جو that has high prevalence is interior uveitis. The interior uveitis is the most common one in the community. Or interior uveitis, past studies will show, has reported that it is about 52 to 90% among the uveitis. And the posterior is from 5 to 21. You see the range. It is a very big range now. 5 to 21%. 5 to 21% is posterior uveitis among the uveitis. So it is, and the same when we are going to the panuveitis and intermediate uveitis. Again, intermediate uveitis is less common, that is 1 to 12% among the uveitis. So intermediate uveitis, posterior uveitis, and panuveitis is less common as compared to interior uveitis. आवाज सही सुनाई दे रहा है؟
جی سر
آپ
رضی سر آواز.
سلائڈ چینج کر رہے ہیں؟
سلائڈ چینج کروں گا، لیکن پہلے میں یہ چیزیں بتاؤں ایپیڈیمیالوجی کے بارے میں، کیونکہ وی ڈونٹ نو ایگزیکٹلی دا ایگزیکٹ ایپیڈیمیالوجی اینڈ نو ون ہیز پراپرلی رپورٹڈ. ٹھیک ہے، تو یہ اس کی ایپیڈیمیالوجی ہے. باقی خاص اس کی جو پریویلنس ہے وہ کمیونٹی میں اتنا زیادہ اویلیبل نہیں ہے، لیکن سب سے کامن جو ہے دیٹ از انٹیریئر یوویائٹس. اس کے بعد جو ہے پوسٹیریئر یوویائٹس، اس کے بعد جو ہے پین یوویائٹس، انٹرمیڈیٹ یوویائٹس، اس کے بعد جو ہے پین یوویائٹس. تو یہ مختلف قسم کے رپورٹس ہیں جو اویلیبل ہیں. تو now uveitis, we know that it is the inflammation of the uveal tract And when there is inflammation of the uveal tract, adjacent intraocular structure will be also affected. Adjacent structure with the uveal tissue, you know, that is sclera and retina and vitreous, and even lens and ciliary body and iris related structure. So the related structure with uh, uveal tissue is your trabecular meshwork that will also be affected. Your pupil size will also be affected. Aqueous production, when ciliary body is involved, aqueous production will also be affected. Retina, when involved, your retinal function, vision will also be affected. When vitreous is affected, again your vision will also be affected. So it depends upon the structure involvement that will affect the function of that structure. Uveal tract, we know that it consists of iris and ciliary body and choroid. Uveitis classification, that is anatomical. First one, interior uveitis, that is iritis, inflammation of the iris. Intermediate uveitis, inflammation of the ciliary body, cyclitis. Peripheral retina and vitreous base involvement, vitritis. Posterior uveitis, inflammation of the choroid and retina, retinitis. Retinochoroiditis. Panuveitis, inflammation of the whole uveal tract. So the structure involvement, and you will give the name to the structure. Ciliary body, cyclitis. Retina and vitreous both involvement, vitreoretinitis. These are the things that you will mention in your lecture, your reporting of a patient of uveitis. Uveitis classification, again, it's etiology. That was an anatomical, and now that is etiology. Autoimmune, infectious, neoplastic, traumatic, post-operative. Now, autoimmune uveitis, idiopathic, sympathetic ophthalmia associated with systemic disease, that is HLA-B27. Don't forget HLA-B27 associated. Psoriatic arthropathy, Crohn's disease, ulcerative colitis, and ankylosing spondylitis and Ritter syndrome. Sarcoidosis, Behçet disease, juvenile idiopathic arthritis, बच्चों में जो है, collagen vascular disease, Wagner granulomatosis, polyarthritis nodosa. Infectious uveitis, bacteria, virus, protozoa, fungus, syphilis, tuberculosis, chronic post-operative endophthalmitis from Propion bacterium acne, virus, herpes simplex, varicella zoster, protozoa toxoplasmosis, toxocariasis, and fungus candida. Now other is acute or chronic, unilateral or bilateral. In 50% of cases, no cause is identified, and it is presumed autoimmune disease. The exact cause is not known. There is another classification. People are also, this was the first one that it is easy to remember. Again, this is the same thing, and some people will classify it like this: interior uveitis, intermediate uveitis, posterior uveitis, panuveitis. Again, site, interior chamber, vitreous, retina or choroid, Anterior chamber, vitreous and retina are choroid include, as we discussed, iritis, iridocyclitis, anterior cyclitis, vitreous pars planitis, posterior cyclitis, hylitis, hyalide membrane involvement. Retina are choroid, focal, multifocal or diffuse, choroiditis, chorioretinitis, as I already told you, retinochoroiditis, retinitis. Panuveitis, interior chamber, vitreous and retina are choroid. So some people will give like this category, descriptor, comment, onset, like onset, sudden onset as we acute and chronic, duration limited, persistent. This is 3 months duration, 3 months duration, course acute, episode characterized by sudden onset and limited duration, recurrent, repeated episode separated. एक मिनट में इसको ये माउस मेरे यार में इसको मैं इसको इंटर कर लो. रिकरेंट किसको कहेंगे? Repeated episodes separated by periods of some people will accept this, but some people will not. But hello, assalamu alaikum. Hello, do you know that? So recurrent will be asked from you. What do you mean by recurrent uveitis? What do you mean by chronic uveitis? So these are the terms that if it is good to know about this. When you will say acute, when you will say recurrent, and when you will, because people are using these words in clinical situation, they will say that is acute uveitis. Some will say acute and chronic. So the disease will be present, chronic, but there will be more sudden acute inflammation. So that people will call it acute and chronic. Recurrent uveitis. So they will mention like this in different clinical situation. So now you know this, that when you will say acute, when you will say recurrent, when you will say chronic, when you will say acute and chronic. So the chronic will be there, it will be running, but there will be sudden acute inflammation. Uveitis is a very, very dangerous thing for the sight and for the eye, both and even systemic. Some people will like this: inactive, worsening activity, improve activity, remission. So people will grade uveitis like this clinically. Because if I examine a patient today and I am not present after 3 days, and I am not clinically entering the presentation that it is grade 1, grade 2, grade 3, so the man that was treated by me will not be properly assessed by another ophthalmologist after 3 or 4 or 5 days, because he will not be able to know the state of uveitis at presentation. But if I enter the clinical science that it is grade 0 cells, grade 2, grade 3, so then he will be able to know about the result of my medicine, treatment, and the response of the patient. Then he will be able to decrease or increase or add some other medicine. So this definition, this is very important for cells. That is inactive grade 0 cells, interior chamber, worsening activity, two-step increase in level of inflammation, interior chamber cell, vitreous has are increased from 3 to 4 cell. Improve activity, 2 steps decrease in level of inflammation, interior chamber cells, vitreous has are decreased to grade 0. So this will be again, there is also another presentation I will give you, but some people will present like this clinically: remission, inactive disease for that is 3 months after discontinuing all treatment for eye disease. Now, what will be the acute interior uveitis symptoms? Most commonly, they will be presenting with gradual onset pain, redness, sometimes sudden presentation. But it will be the gradual symptoms will be within hours, like 48 hours, like 24 hours. So then they will be presenting with severe pain, redness, and photophobia. Signs are circumcorneal hyperemia, injection, meiosis, posterior synechia, cells and flare in the interior chamber, keratic precipitate, sometimes high intraocular pressure. Acute interior uveitis is usually unilateral, but it may be bilateral. So this is important, sometimes acute interior. And most of the time, clinically, we are not going for the lab work because we know that 50% will not be giving any clue to you. So we just treat cycloplegic and steroid anti-inflammatory, and we consider them as a autoimmune. So this will be treated like in this way, but we are not going for lab work in for first time presentation and for unilateral presentation and for acute interior uveitis. So lab work is not so important in acute interior first time presentation. If again they are presenting with um, uh, repeatedly, so then we will go for investigation. Our first time interior uveitis, even bilateral, we are not going for a lab work. But if they are presenting repeatedly, then we will go for lab work. Acute interior uveitis that we conjunctival, we know the now injection, the pupil has been dilated with cycloplegic, and we know the circumcorneal injection, limbal. This is the common presentation whenever you see conjunctivitis. Don't forget to examine the interior chamber. Remember. Now this is the acute continuity of the acute uveitis. You see the pupil size, you see the hypopyon in the interior chamber, and you can see the fibrosis, white lines in the interior chamber. You see this reaction. So this is the exudates that are formed in the interior chamber on the iris, and you see the hypopyon in uveitis. And different systemic disorder presenting with hypopyon and uveitis. Now this is membranous. You see the membrane here, fibrinous membrane, that is again protein and cells reaction deposit on the endothelium and interior chamber, and you see the irregularity of the pupil posterior synechia. Now you see the eye is quiet, has been treated, but the capiz, that is the typical capiz, keratic precipitate, that is called capiz, are present, and these are called mutton fat capiz, globules like mutton fat. So these are the presentation that may be present for a long time after treatment, and they will affect vision of patient. Now, how you will grade this interior uveitis, as I mentioned in the first, aqueous flare inflammatory cell in the interior chamber. So cells and flare. Now we will just come for the cells now. That cells flare, the next slide will show you cell. So the slit beam will be 1 millimeter slit and 1 millimeter height, and grade 0. less than 1.5, 1 to 5 cells plus 1. So this is plus 3 plus 4, and the cells will be like this. So you will be writing that uveitis plus 1, uveitis plus 2, and plus 2 means cell 1525, and you are treating and it is decreasing, then you will say it is plus 1. So again, treatment and acuteness will be graded by be judged by this cell's presentation. Interior chamber flare, that is protein, grade 0, plus 1, plus 2, plus 3, plus 4. So this is again iris and lens detail clear, iris and lens detail hazy, fibrin or plastic aqueous. I already show you the pictures of that uveitis. Now here irregular pupil with posterior synechiae that may be present in the acute stage, that is for 3, 4, 5 days, and after treatment some people will be presenting pupil like posterior synechiae like this if they are treated late in their onset. So if you let, the patient is going to tolerate, sometimes the people will tolerate pain and they will go to the others health workers, that is quacks, and even some will go to put some oil and some eggs on their eye, and they will be delaying their presentation, and they can go to this type of uveitis even after treatment. Now this is again the posterior synechiae you see here in after treatment. It is important to treat and diagnose and treat anterior uveitis as early as possible to avoid this complication. Now we will come to intermediate uveitis. That is the most common symptom in intermediate uveitis is floater. Remember, whenever patient present with floater, don't forget to examine the fundus with dilated pupil. Every patient in the clinics, OPD, you must, any patient present with floater, some will say that is just like मकड़ी के जाले की तरह, बाल की तरह, मुख्तलिफ किस्म के लोग दायरे की तरह. So you must dilate the pupil and you must see the fundus in detail. Gradual blurring of vision that will be painless. Signs are inflammatory cells and opacity in the vitreous, cystoid macular edema, peripheral retinal vasculitis. These will be present in patients with intermediate uveitis. It is less common, but intermediate uveitis, we know that ciliary body, pars plana, vitreous base. Actually, it is the vitreous base that is involved in intermediate uveitis. Now we can say the causes of intermediate uveitis are differential diagnosis. Both in this picture, both are included. These are the differential diagnoses and these are the causes of uveitis. So you will treat accordingly. Lyme disease, syphilis, toxocariasis, toxoplasmosis, tuberculosis. Immune idiopathic, 70%. Now you can see 70% are idiopathic. Pars planitis, 36, sarcoidosis, and multiple and others. It is not the and multiple sclerosis and others. Grading of vitreous hairs. Now you can see the picture here. So this is no flare. Fundus is clearly visible. Again going hairs, again going hairs, again going hairs, again no visibility and less visibility, that is grade 4. So this is from the reverse severity. Severity, 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 less severity, less severity, and less severity. So no flare, traces, cells, optic disc, and vessel, hazy narrow fiber layer, hazy optic disc and vessels, optic disc visible, optic disc not visible. This in this little bit you can say it is here again it is not visible, but you someone can say that it is visible, and here totally absent because of the vitreous inflammation. Protein and cells cover the whole vitreous, and we are not able to examine the structure. So this is the grading of you. Clinically, these three types, clinically, to know about the severity of uveitis: anterior chamber cells, flares, and vitreous has flare. So this is important clinically for treatment purposes. You will remember this, and I will give you this lecture to you today. Asad is in Pico. Fundoscopy. Characteristic mobile globular yellow-white snowballs that is called ants egg, और जो चूंटियों के जो अंडे होते हैं, सीन इन द इंफीरियर पेरिफेरल विट्रियस, क्योंकि वो सीन कर लेते हैं इंफीरियरली, इसलिए होते हैं कि वो ग्रेविटी के लिए उस पे आ जाते हैं विट्रियस बेस पे. They lie close to the retina but are not in contact with. Some will be in contact. It is not necessary. It will the inflammation will not follow the book. Inflammatory exudate accumulate over pars plana to form snow banks. Periphlebitis are peripheral veins in vicinity of exudates. So the vessels, the veins will be covered by inflammation. You will see the picture. Later, the vitreous show degenerative changes with fiber-like cylindrical condensation of coarse vitreous strands. Posterior vitreous detachment is common. Retinal changes include tortuosity in arterioles and venules, sheathing of the peripheral veins, neovascularization, and this is again the inflammatory changes signs. If you see cells are there and they are going in clumps, they will form snow banks, floaters. So cystoid macular edema. These are the changes when there is exudates, inflammation of the veins. So inflammatory cells will cover the vein. So that is called sheathing of the blood vessels clinically. They will cover the whole veins by the inflammatory products like these cells and these proteins. Now these are the fundus pictures that we can see. Fundoscopy showing evidence of your vitreous cells by slow slit lamp. You can interior vitreous surface will be visible. These cells will be behind the lens for this. Now, choroidal retinal scarring will be there after the healing. Now, snow banks, you see the deposit at the inferior surface of the vitreous base, inferior portion. And snowball, you can see the clumps of the protein and cells. So these are the snowballs in the vitreous. And vitreous has complete. So you can see now the vitreous has because of the inflammation. Large vitreous floaters, it is very difficult to differentiate between this and sometimes retinal detachment. But again, if you see it, that will be with your binocular vision, then you can judge that it is in the vitreous or on the retina. Here there is detachment, vitreous detachment. You see the haziness of this, and B scan will tell you. Sometimes it is very difficult to examine this when there is vitreous haze. Whenever there is vitreous haze, you are not able to see the fundus in diabetics and vitreous hemorrhage in trauma. and white cataract. Before going for white cataract surgery, you must, any other apart from uveitis, whenever you are not able to examine the fundus, you must go for B scan. This is the rule, golden rule. If I go to cataract surgery and I don't know about the posterior segment, on removing the pad on the first morning, the patient will not be able to see. Now, I will be in shame, you will be in shame, everyone will be in shame, and the patient will not accept that it is before the surgery or intervention, and all the responsibility will be on you. This is the golden rules whenever you are not able to see the fundus in any condition apart from uveitis or others, including uveitis, not apart, including uveitis, you must go for B scan. This is golden rule. Now you can see this deposit on the macula, macular edema, and you can see this deposit and clear liquid retina. This is the vitreous detachment, and it can lead to retinal detachment. So this is again snowballs. Now in this slide, it is clear this is on the inferior vitreous base, and snow banking. More inflammatory cells are present here. Now FFA detection. Rarely we are going for nowadays for FFA because we have OCT. Now capillary and disc hyperfluorescence staining of vessel wall and fan pattern radial hyperfluorescence. You can see this uh, presentation just like petals of the flowers. So this is the typical presentation of this foveal presentation, and you can see the hyperemia of the disc, and exudate will be stand more like this. This is the exudates that is stand here. Now macular edema will show you these cystic changes. Whenever we are presenting this slide to you people, you always say that it is CSR, and then we ask, yes, it is CSR, but other condition. So now you know that uveitis, cataract surgery, cystoid macular edema, diabetic macular edema can present with this type. Now it is important to know about the history, examination, and then lab work. Lab investigation. This investigation, I have written this in this intermediate uveitis, but this can be applied to all interior, posterior, intermediate uveitis. Baseline investigation, complete blood picture है, ESR है, renal function test है, liver function test है, और PPD test है जो ट्यूबरकुलोसिस के लिए करते हैं, और सर्काइडोसिस, चेस्ट एक्सरे, ये अगेन सर्काइडोसिस और उसके लिए करते हैं, ट्यूबरकुलोसिस जो हमारे यहाँ कॉमन है, फाइंडिंग इन इंडिकेटिव ऑफ सर्काइडोसिस, CT scan lungs, ACE enzymes, serologic test for cat scratch disease, syphilis, VDRL test, FTA, ABS, and Lyme disease, and Lyme's and HLA-DR2 typing, and vitreous step. Vitreous step means that we take sample biopsy of the vitreous. Treatment, again, we will start it from topical, cycloplegic, eye drops, steroids, subtenon injection, again depend upon the severity. It is not necessary that whenever you see that may be quiet, they may be only need steroid for long time. They may be less severe as we see the fundus haziness. So it is not necessary that you will give the all treatment. It is accordingly. So cycloplegic steroid is commonly used both interior, posterior, and intermediate uveitis. But the other like subtenon injection you will think about and you will refer this patient. And Systemic steroid, again oral steroid in high doses. So you, before giving this, you must go for the lab work first to know about the level of the kidney, disease of the kidney, liver function test. Then you will start this steroid because that will be for long time. And support your treatment for steroid, because this steroid will affect, if you are going to give this to the older people, then there will be changes in the bone and they are more prone to bone fractures. Appropriate antibiotics, so add with vitamin D and calcium when where you are going to give systemic steroid, and check blood pressure because that will increase hypertension, that will leads to hypertension. Now, sometime we need laser cryoplastic for new vessels when they are formed in uveitis. PPV, persplana vitrectomy for vitreous opacities when the eye become quiet, the inflammation is subside, but the opacities are there and the patient vision is affected by this opacity. If it is grossly affect the cells vision, then we go for vitrectomy. And again, systemic, if the systemic steroid, all these things are not, or there is some contraindication for systemic steroid, then we go for steroid sparing medicine like sporine and metabolic antimetabolites, azathioprine. So that will be for long years, a whole life. Sometime they will be taking this medicine, and there are complication of this medicine, and you will refer this patient for complication to see the complication, liver function test again. So systemic, there will be systemic changes like hair loss will be there. So you will be looking for all these things. And for you people, my advice is that you, if you see and diagnose uveitis, interior uveitis, you will just, it is good, but I think it is excellent just to give steroid and cycloplegic and refer to the specialist. Then they will be thinking about this. All the facilities will be there, B-scan will be there, so then laboratory will be there. Some advocate use of combination of both steroids, intravitreal, both steroids and anti-metabolites and vitrectomy. So different approaches people will do in, the patient will be called many times to the hospital. There will be multiple visit of this type of patient to the hospital. Some new medicine, this is for your knowledge. These are the some medicine that are now, I didn't use this medicine, but in modern, in Europe and US, people are trying this medicine. But here, apart from azathioprine that we are giving this medicine, I have not seen some people inflexim anti-TNF. We give this in our unit for, I think, 5 or 6 patients, but not in routine in clinic cases. It is more expensive. बहुत ज़्यादा लाखों में इसकी कीमत है, इसकी प्राइस. Treatment of complication, again in uveitis, intermediate, ये तो treatment मैंने intermediate uveitis के साथ लिखा है, लेकिन in any uveitis, whenever this complication develop, you will treat them along with uveitis. So there will be need of cataract surgery, there will be need of glaucoma treatment, you will be giving topical steroid and you will be giving anti-glaucoma medicine. You will be treating that for vitreoretinal changes, PPV, systemic changes due to treatment, others. So systemic changes due to treatment, azathioprine, there will be hair loss, there will be eye changes, macular changes, your skin changes, your kidney function changes. So you will be all looking for this type of complication, even of the treatment. Now, these are the guidelines for treating intermediate uveitis or uveitis. So they will say mild vision is, but here we are not concerned with the vision. We just, whenever we see these uveitis patient in initial stages with good vision, maybe vision with 6 9, then again I'm going to treat. Why I should wait in this community to develop posterior synechiae and fibrine and hypopyon. So this is, but some units abroad will use this guideline. This is for your knowledge. You must know like these things in YY in examination. Moderate to severe vision is less than 612 are having cystoid macular edema, and periocular macular edema, periocular deposit, depot steroid. I mentioned here that there are some steroid that are injected in the ciliary, at the ciliary body portion, and they remain for months, and that the price of this steroid depot is about 150, 1,50,000 की एक वो है. ये हम CRV उसमें देते हैं BRVO or central retinal vein occlusion and long-standing this severe posterior uveitis, intermediate uveitis. Again, if it is not responding to the implant of this type, then add systemic steroid. And this is for the more modern and well-equipped unit. Non-immunosuppressio, that is antimetabolites, steroids, and cryotherapy to vitreous base, that is also laser, because for the neovascularization, and non-responding again vitrectomy. So this is the guideline given by some good units. This is for this is, remember, this is for the intermediate uveitis. But again, we can use it for posterior uveitis as well, depend upon the situation, presentation. Posterior and pen uveitis, symptom acute or gradual blurring of vision, floater, sometime presenting with pen, sometime. They will mainly present with blurring of vision, remember. And there will be sometime pen. Signs variable, choroiditis will be there, optic swelling, retinal vasculitis, vitritis, interior chamber inflammation in pen uveitis. So the whole pen uveitis means all the structure involvement. This is a heel choroiditis. You can see the blood vessels of the retina covering this lesion. You see these blood vessels. By looking this covering of blood vessel, now you will say that it is choroiditis, because retina is now healthy and fundus is clear, and now these scarring of the uveal tissue is because of the inflammation exudate, and now they are healed. Now you can see the macular changes from the choroid side, and it is now the inflammatory cells involve the macula, and scarring of the macula has been developed along with choroid. So now it is, the patient will be having decreased vision. Don't comment on the involvement of macula and vision. Vision may be even 612, but if you see, some student will say that it is, that may be blind because the macula is involved. Don't comment only on the vision. That you will say, you will, if I ask any examiner, ask you what will be the vision you think in this patient looking this slide, so you will say that it depends upon again the severity involvement, and I will physically, practically check the vision. Don't comment on this. It may be, you can say that it may be 6.6 even, it may be 6.9, and it may be 6.60. But again, I will check his vision. So that will be the answer from your side. Don't say that person will be blind. Assessing patient with uveitis. Now, history and eye examination to classify according to anatomical diagnosis, past medical history, review of symptoms, general medical examination to form differential diagnosis, relevant investigation. Now, anatomical diagnosis, clinical characteristic, patient age and demographic, onset of disease, past medical history, full review of system considering non-systemic disease associated differential diagnosis following history and clinical examination. As I told you, uh, basic investigation performed as I mentioned in intermediate uveitis again here, and X-ray chest, sarcoidosis, tuberculosis, other depend on differential diagnosis. TB, Monto test, chest X-ray, sarcoidosis, chest X-ray, serum ACE, enzymes, serum calcium, ankylosing spondylitis, sacroiliac giant X-ray, HLA B27, vaginal granulomatosis, anti-nuclear antibodies, chest X-ray, CT scan of sinuses, retinal investigation, B scan वगैरह, FFA, OCT, treatment of acute anterior uveitis, that is I already mentioned topical corticosteroid intensive first and then taper. Dilating drops to prevent formation of posterior synechia and relieve pain, cyclopentolate, atropine, anti-glaucoma medication if necessary, subconjunctival steroid injection if fails to respond to eye drops. Periocular injection, oral, intravenous, systemic immunocyclosporine, tacrolimus, mycophenolate, mofetil, azathioprine, methotrexate, needs close monitoring for side effect. For these things, systemic immunosuppressive, whenever you are giving immunosuppressive, they need close monitoring. Don't forget the patient, don't free the patient that you are now free. They should have, he should come for visit, and you will go for the lab work to see the complication of your treatment. Now complication, we know that glaucoma, permanent visual loss, optic neuropathy, macular damage, and retinal detachment. Now I think we should stop here. There are some specific disease that we will discuss in the coming lecture. So at present, I'm going to stop. There is nothing in serious, but it is mainly the examination of patient that you will detect on slit lamp. It is very difficult to detect it on torch. You must have in your clinic slit lamp. Don't treat patient without proper examination. Don't treat patient at present situation with torch examination. So it needs proper detailed examination. One thing, remember these things. Other is that for you people start on cycloplegic and steroid, then refer the patient for further management. Management will include history, examination, lab work, and treatment. This is the main thing. And keep in mind, uveitis is a blinding disease, and it can be run throughout life. There may be need of treatment for a long time. So don't consider them as a, that is uveitis, but uveitis hai aur treat ho jayega. No, you must take care of this patient. But again, in complication of interior uveitis are less, unilateral uveitis and even bilateral uveitis are less as compared to intermediate uveitis, posterior uveitis, and panuveitis. And interior uveitis will not need lab work for the first time or even for the second time. Okay?
Sir,
G.
sir, why lab work is not important in acute interior uveitis in first visit?
पर इंटीरियर यूवियाइटिस की बात कर रहा हूँ कि क्योंकि हम जब भी हमारी स्टडीज हैं, हमारे अपनी स्टडीज भी हैं HMC के, प्रोफेसर एब्रार ने भी हमारी HMC में इस पे स्टडी की है कि जितने भी यूवेटाइटिस के हमने विट्रियस टेप्स लिए थे और जितने भी स्वाब लिए थे तो वो सारे के सारे इडियोपैथिक आ गए हैं, किसी चीज में फिट नहीं हो रहे थे, ना इन्फेक्शस में किसी चीज में। लेकिन जितने भी सारे हैं जो इसलिए हम जो दे रहे हैं, कौन से मेडिसिन दे रहे हैं, साइक्लोप्लेजिक और स्टेरॉइड देते हैं। हम सोचते हैं कि ये ऑटो इम्यून ट्रीटमेंट है। अभी कौन से ऑटो इम्यून डिसऑर्डर है इसके लैब वर्क में अभी तक कोई खास पता नहीं है। देयरफॉर वी आर नॉट गोइंग फॉर लैब वर्क, जो स्टडीज की बुनियाद पे है, क्योंकि लोगों ने हमें रिपोर्ट किया कि हमने बहुत से पेशेंट के पैसे लगा के खर्चे करके फिर भी हमें कुछ स्पेसिफिक डिजीज का पता नहीं चला। ठीक है, इसलिए यूनिलैटरल या रेयरली बाईलैटरल इंटीरियर यूवेटाइटिस हम लैब वर्क में नहीं जाते। हाँ, अगर वो बार बार रिपीट करते हैं इवन यूनिलैटरल, देन वी विल गो फॉर लैब वर्क। चेस्ट एक्सरे पे जाएंगे, फिर ESR और मॉन्टो टेस्ट और ये चीजें करेंगे।
Okay, sir.
और यहाँ तक किसी की
सर
समझ
ये इनएक्टिव यूवेटाइटिस
बड़ी
का हमें
जी बेटे
सर ये इनएक्टिव यूवेटाइटिस को हम क्लिनिकली किस तरह वो देख सकते हैं?
जो
किस
मैंने
तरह पता
बताया वो
चलेगा?
क्वाइट होते हैं, उसके इन्फ्लेमेटरी सेल्स जो हैं और जो इन्फ्लेमेशन के कितने साइंस हैं, इन्फ्लेमेशन के कितने साइन हैं, नाम इन्फ्लेमेशन के साइन कौन से होते हैं?
5 सर।
हाँ
4%, sir. 4%.
5 है सर, 5
हाँ, तो कौन कौन से हैं?
सर। रेडनेस होता है,
Pain,
फीवर होता है,
redness.
पेन होता है,
हाँ?
लॉस ऑफ सेंसेशन, लॉस ऑफ फंक्शन, सॉरी,
एग्रीगेशन ऑफ
आखिर में लॉस ऑफ एडिमा होता है ना, फ्लूइड भी आ जाता है ना,
जी
स्वेलिंग होता है ना उसमें।
जी सर।
हाँ, तो हमें रेडनेस, स्वेलिंग और एक्टिवनेस जो सेल्स हैं, जो मैंने कहा कि कितने सेल्स हैं, इसलिए तो लोगों ने ये क्लासिफिकेशन ग्रेडिंग की है कि ये ग्रेड 1, 2, 3। तो अगर वो क्वाइट है तो आपका ग्रेड आ जाएगा ना उसमें स्लिट लैम्प पे कि ये अभी क्वाइट हो रहा है, तो आपको पता चल जाएगा कि ये क्रॉनिक है और अभी इसका ग्रेडिंग इतना था पहले, अभी ग्रेडिंग इतना है, तो ये क्वाइट है। वो क्लासिफिकेशन जहन में रख के फ्लेयर्स और सेल्स का इंटीरियर चैम्बर में और पोस्टीरियर चैम्बर के लिए, विट्रियस के लिए, स्नो बॉल्स जो हैं, इवन sometime some will be disappear, but those who are more and the structure are not able to absorb, then they will again present and they will disturb your vision, and then we will go for surgery. Otherwise ये तो ग्रेडिंग पे हम देखते हैं कि ये अभी क्वाइट है या नहीं है। ठीक है,
और सर ये केसेस जो बनते हैं ये क्वाइट होने के बाद बनते हैं, इन्फ्लेमेशन स्टॉप होने के बाद बनते हैं?
ये तो ग्रेडिंग है, ये तो सिवियरिटी पे डिपेंड है, इसमें तो इस तरह वो नहीं है, ये तो ग्रेडिंग है, सिवियरिटी शो कर रहा है। ये तो ये नहीं है कि ये बाद में बनेंगे या अभी बनेंगे। अगर एक्यूट इन्फ्लेमेशन 48 आवर्स में शो रहे हैं और सीवियर हैं तो ये हाइपोपियन के साथ भी प्रेजेंट कर सकते हैं और फिब्रिनियस एक्सोडेट के साथ भी, और भी कुछ टर्म है जो दूसरे डिजीज में आने वाले हैं, जिसको कोएप नोड्यूल्स कहते हैं, बोसाका नोड्यूल कहते हैं, वो भी आएंगे। नीचे जो अवर स्लाइड्स है उसमें आयरस में जो नोड्यूल्स बनते हैं वो भी एक साइंस है जो आएंगे दूसरे स्लाइड्स में। तो मुख्तलिफ इसके जो प्रेजेंटेशन है, इस पे ग्रेडिंग के बेस पे हम उसको सिवियरिटी जज करते हैं। ठीक,
जी सर।
जी सर।
uveitis is a blinding disease. uveitis is a, ये मेरे अल्फाज हैं, uveitis is a blinding disease. ये जहन में याद रखें, इसलिए कि ये सीरियस ले लें इस चीज को। uveitis is a blinding disease, खासकर जो posterior uveitis और intermediate uveitis है, these are blinding disease. So uveitis is a very very complicated things clinically and patient wise جو ہے یہ ٹھیک ہے. تھینک یو. میں نے آج آپ لوگوں